Okay, well, let's go ahead and get started. Hello, everyone. Welcome. I'm Dominic Tarpey. I'm a member of the committee that helps organize this series of grand rounds. This is the Intensive Services Grand Rounds at the Department of Psychiatry and Behavioral Sciences at UCSF. So I'm honored and feel very fortunate to have Dr. Lisa Pascual presenting to us today regarding physical medicine and rehabilitation and psychiatry. And so I'll go ahead and just introduce Lisa and then turn it over to her. As I think everyone knows at this point, just feel free to push out your questions via the chat, and then we'll address them as we go along or at the end. Dr. Pascual did her training at UC Davis, including her residency in physical medicine and rehabilitation. And she is a diplomate of the American Board of Physical Medicine and Rehabilitation. At UCSF, she's clinical professor of medicine and section chief of physical medicine and rehabilitation. I think this is accurate. Her primary home is at Zuckerberg San Francisco General Hospital and Trauma Center, and there she is chief of rehabilitation services and is on the active medical staff in orthopedic surgery. Additionally, she is the chief of rehabilitation services at Laguna Honda Hospital and Rehabilitation Center here in San Francisco and senior physician specialist. And finally, she is an attending physician at California Children's Services in the Medical Treatment Unit. I could say more, but I will turn it over to Dr. Pascual and go from there. Thank you.
Thanks very much. Thanks again for having me today. It's really nice to be approached to talk about rehabilitation, especially in the inpatient psychiatry setting. So the learning, let's see if I can get this going. The learning objectives for today include becoming familiar with common rehabilitation-related medical issues in patients who have primarily spinal cord injury, traumatic brain injury, and also stroke, and I'll tell you why in just a second. Here at San Francisco General, I'm also a consultant on the inpatient service and also do inpatient consultations on the psychiatric unit when called upon. And when I was asked to give a sort of a primer in terms of the rehabilitation care of patients on an inpatient psychiatry unit, I tried to think of what rehabilitation aspects of care might be the most helpful for the management of patients who do have particular rehab needs. So I approached this lecture from the perspective of a physical medicine and rehabilitation consultant when I'm called to see patients on the psychiatry unit. And the most common diagnosis that I usually am called to see is related to patients who have spinal cord injury, traumatic brain injury, and stroke. So in this lecture, I wanted to include rehabilitation aspects of their care that might be unique to those diagnoses, but maybe a little bit less familiar to not only the psychiatry service, but also to other services that may not be used to treating this patient population, especially as these particular areas do have do affect the patient's psychosocial well-being. So in rehab, we have a lot of devices and a lot of medications and drugs that may or may not be familiar to other, even just the medical unit or other acute units in the hospital. And I wanted to start to begin to familiarize you with some of the things that we often are called on to consult on when we have patients like spinal cord patients, head injury patients, and stroke patients on your unit. So in terms of spinal cord injury, let's just start off with statistics. I have a polling question. This whole Zoom lecture thing is a little bit challenging because I can't see and interact with the audience, and this seems to be like maybe the only way to interact with you to see if you're out there. So if you wouldn't mind answering the poll here, what do you suppose might be the most common cause of spinal cord injury? And we're already getting responses, which is kind of cool because I know there are people out there. So, okay. Okay, so yes, the two choices that were neck and neck were falls and motor vehicle crashes. And interestingly, number one is motor vehicle crash, but the second one is falls. And it's interesting in that, let me see if I can move that out of the way. There we go. It's interesting in that, let's go from here. That here's the percentages. So y'all were pretty close in your guess. Here in San Francisco, it's less due to motor vehicle crashes because we don't have sort of that freeway infrastructure that one might see in LA or in other parts of California. But we certainly do have a lot of falls. Certainly here at the General, when we have neurotrauma rounds, it's mostly somebody who's falling from standing or falling down the stairs. Usually somebody who is older, which is reflected right here when we're looking at the age range of people who have falls. And if you look, let's see, it's going to be probably on the next. Oh, actually, let me just mention, it is a bimodal distribution in terms of motor vehicle crashes and falls. So motor vehicles is number one. So here's another polling question. More males than females sustain spinal cord injury. True or false? Yeah, that was that was really good. Okay, here we go. And it looks like this is predominantly going to be the answer. It is males, and this statistic is similar also to traumatic brain injury, where it is mostly males who are sustaining both spinal cord injury and traumatic brain injury. And it tends to be young males. So when we're looking at, and I'm going to move this out of the way and proceed with the next slide. When we're looking at the distribution of age, it's usually a bimodal distribution where you see the young males kind of in the front, and then you have the older population as the other increase in the bimodal distribution. And it's that older age of falls that is skewing the mean age at injury higher over the past few years to a mean age at injury is about 43. Okay, another polling question is coming up, which is the most common type of spinal cord injury is paraplegia. I think we've got kind of a good idea what the group is thinking. Yes, that is false. The most common injury happens to be either tetraplegia or quadriplegia, and more specifically, it's incomplete quadriplegia. And actually, that is something that's important to note, because an incomplete quadriplegia, let's see, sorry about that, tends to be the most common type of injury, and it is also a central cord syndrome. I don't know if people remember from way back from neuroanatomy what a central cord syndrome is, but that tends to be an injury where the arms are more affected than the legs. So sometimes it can be described as sort of kind of like a Frankenstein movement, where the arms and the fine motor coordination of the hands aren't working as well, and the legs are stronger. So they're sort of walking, but their arms aren't kind of functioning normally. And that's essential cord syndrome, which is important when we think about prognosis. And we'll touch upon that in just a sec. So here's a common scenario. If you're doing inpatient consults on the unit, it's not uncommon to have this happen. So here's a case of a 25-year-old male who was involved in a motor vehicle crash, who sustained a C5 fracture dislocation. And he has something, what we're calling a C6 Asia A quadriplegia. We're going to talk about what that means in just a second. He states that no one has told him whether or not he will walk again, and he wants to know this prognosis. This is perhaps one of the most common questions that any member of the team, the primary team or the consultant team, can have posed to them. And sometimes it takes you aback because you may not be ready for it. And although the primary team may have already discussed this with the patient, there's so much going on during the admission and after the injury that either the patient may have been too medicated to understand what was going on, it was too difficult to process for them, they didn't understand the explanation, or perhaps are even seeking a different opinion from what they were told. So it's not unusual for nursing staff, therapists, outside consultants to be asked this question of the patient. And it's important for us to be able to at least respond, give the patient an informed description about what to expect in terms of their functional status. One of the first things that we have to think of is how severe is the injury. When we think of quadriplegia or spinal cord injury, we often envision somebody who's maybe, this is like the movie version, where somebody's in a power wheelchair, they are unable to move their arms or their legs. That's a very sort of typical kind of picture that we think of when we think of a severe quadriplegic. But spinal cord injury comes in a lot of different flavors, and a wide variety of functional statuses can occur or can come from a spinal cord injury, such that this gentleman is also spinal cord injured, but it's clear that his injury was not as severe as the person on the left. So it's important to have an idea of what type of injury somebody has. Well, when you're walking into this is him where he's actually walking where the other patient is not. When we're walking into a room and you've had the opportunity to review the chart and you see something that says something like C6 Asia A, what does that mean? And what it's pertaining to is something called an Asia classification or an INSCI examination. It's a way that we classify spinal cord injury so that people understand the severity of the injury, and it's also a common language for us to convey to somebody else on the team how significant an injury might be. This is kind of a really busy looking chart. But it's important to know, in case you walk into the room or in case you're admitting a patient who in their discharge summary has some reference to an Asia classification. So for example, the Asia classification does two different things. It will give you a neurological level of injury, something like C5, L1, T2, T3, and will also give you an Asia impairment scale letter, A through E. And that refers to the completeness or the incompleteness of an injury. So for example, in this particular patient that scored out on the Asia classification, we can see here that, let me see if my arrow works. Hopefully you can see my arrow, that when we go from head to toe, we start grading how somebody's sensation is either impaired, normal, or not present at different dermatomes. And we also see, we also look at major muscle groups from biceps, from their elbow flexors, their wrist extensors, down to their legs, quads. And we also grade their strength in those muscle groups. We start from the head and we kind of look downwards and see where they become impaired. So here, 2 means normal, 0 means they don't have any sensation, and 1 means it's impaired. So we can see from this particular example, they have sensation intact to light, touch, and sharp on the right side all the way down to C5. And in fact, their elbow flexors, which are in the C5 myotome, are also intact. It's the same on the other side as well. So that means that down to C5, that's their neurological level of injury. Things are normal all the way down to C5. So that's part 1. And for here, you can see the on the other red circle down below that their neurological level of injury is C5. Then we look at 3 different things to determine whether or not somebody has a complete injury or an incomplete injury. A complete injury, as you can imagine, is a very severe injury. It basically means they don't have any movement, motor or sensory, below the level of, in this case, C5. So that's a pretty devastating injury. If somebody has any one of these 3 things here, either voluntary anal contraction, sensation around the rectum, or deep anal pressure sensation, then they are deemed incomplete. And that's super important when we're thinking about prognosis for a patient. So for this particular patient, they unfortunately did not have any of these things, sensation or motor function around the rectum. So they are deemed complete. And when you are complete, you are determined an Asia impairment scale A, which intuitively you would think would portend a poor prognosis. And in this case, this patient could be somebody who might be an ASIA A, where he's unable to move his lower extremities. He may not have sensation to his lower extremities or parts of his arm as well. So the ASIA grades, A refers to complete, as we mentioned before, and E refers to normal. And anything in between, B, C, or D, gives you an idea of how incomplete somebody's injury is. So as you go lower to D, the more and more incomplete the injury is. In other words, when you get to D, a lot of muscle strength is preserved on examination, which is good. It makes sense that would be good for a patient. So you, of course, would much rather want to be somebody who's in the C or D range, or better yet, E range, than somebody who is in the A range. A second example might be this particular individual, where we can see here that his abnormalities begin around C4. So his neurological level of injury would actually be C3, because that's where his last normal level is. And that's denoted down here at the bottom of the form. In this patient's case, we note that he has things going on in his rectal area, voluntary area, anal contraction. He has some sensation around his rectum, and he has deep anal pressure. So technically speaking, he is incomplete, which is super important for his prognosis. And on top of that, when you look at his motor strength over here in these columns, you'll see that the muscle strength is graded around 4 to 5. There are some 2s over here, but pretty much he has a lot of preservation and strength. And because of that, when you do all of the grading, you'll find that he happens to be an ASIA impairment D, which is extremely good. And the patient here might look like somebody like this gentleman who is actually ambulating. So in terms of recovery, when you're reviewing a chart, either in consultation or if you've received a patient who has some sort of mention of their ASIA classification, A, B, C, D, you'll have a much better idea of what somebody's prognosis might be. An A, not so good in terms of improvement to some real meaningful motor recovery, whereas B and C have a tendency to improve to the next grade up over time, which is really important. And this is schematically seen here as well, where you're seeing improvement in people who have grades B, C, and D, and less so in patients who have a grade A. So here's the polling question. Which individual with the following AIS classification would likely be the most functionally independent in terms of ADLs and mobility? Somebody who has a neurological level of a C2 injury, but is ASIA D, or somebody whose functional level is a C6 patient, but is ASIA B? Sounds terrible to be a C2 ASIA, C2 quadriplegic, but if you look at, and I think people recall that D is much better than A, is much better than B. It is true that from a functional standpoint, if you see somebody who's labeled as an ASIA D, their prognosis will tend to be much better for functional recovery than that of somebody who is an ASIA B. Just going to move this poll aside and then move on. And it's these type of patients who tend to be central cord syndrome patients. They're incomplete, which is good. They tend to have strong legs, which gives them good motor scores at their legs. These tend to be elderly patients who have fallen downstairs or fallen down the floor and had a hyperextension injury. And overall, anybody with a central cord syndrome tends to have a better prognosis for ongoing functional recovery than somebody who might be an ASIA B or an A. This gentleman is an example. Here he is just starting to take his first steps, beginning to do some activities without the use of the assistive device. And then here, walking more functional distances. And really by the time that I saw him next, he was walking without the use of an assisted device. So some really good recovery as somebody who, in his case, he started out as a Asia C patient. Okay, so going back to that case example that we talked about for this gentleman who asked you what his prognosis might be if he were C6 Asia A quadriplegic. One of the thoughts, one of the potential answers that we know about in our head is that the prognosis is pretty guarded because he is Asia A. However, there is evidence that improvements over time can occur, and particularly the improvements can go from 1 to 2 years. We generally tell patients that their most rapid improvement occurs within the first 6 months following an injury, and that hopefully will give them some trajectory of their recovery. On the inpatient unit, we see a lot of different devices. This is probably not a device that you would see on your inpatient unit, because if they needed a Hoyer lift, they probably are likely too much hands-on care to be on your unit. However, you may see this particular device on your unit. This is a sliding board. It's a device that assists patients from moving from surface to surface. And it can be used for not only spinal cord injured patients, it can be used for any patient who has difficulty supporting their own weight with their extremities to perform a safe transfer from one surface to another. There are other devices that our spinal cord injured patients may use that we hope you might consider if you're finding that your patients on the unit are having difficulty with either eating or performing their ADLs. This is a universal cuff where different devices can be inserted into the cuff to facilitate performing activities of daily living. And there are also other devices where patients can have extended straws where they can give themselves their own liquids and drink on their own without having staff to assist. Other devices that may be familiar to you are also orthotics. So there's a difference between a brace and an orthotic, or a splint and an orthotic. A splint is something is to put an extremity in a particular position, and a brace is an orthotic is something that actually provides some functional use. And in this case, this is an AFO, an ankle foot orthoses, which may be used for ambulation if somebody has weakness in their plantar flexors or dorsiflexors. If they have quadricep weakness, we may move on to a what's called a KAFO, a knee ankle foot orthoses. And it's probably not unusual where you've seen these big tortoiseshell devices, which are thoracic lumbosacral orthoses for patients who are recovering after spinal fusion. Other devices that you're probably very familiar with are walkers. It's usually the physical therapist who makes recommendations on the type of a walker somebody uses. Once you put wheels on walkers, they become more unstable for a patient. So you'll need to make sure that the walker type that you have is the safest for the patient. Certainly, this is more mobile, but also more unstable for somebody who has difficulty with balance. We then tried to move people onto less restrictive devices. This is a quad cane, which has less of a base of support, but easier to use for mobility in areas where there's not a lot of room if they're going up and down stairs. And certainly, we hope that somebody can move on to the use of a cane or no assisted device if possible. With ambulation on the unit, there's always the risk for falls. So the therapist will often let you know if somebody needs standby assistance or contact guard assistance to ambulate on the unit. Whenever using braces, here it's always important to look for the presence of skin breakdown to make sure that the patient's not developing skin irritation because of insensate skin. In spinal cord injured patients, they have problems with autonomic functioning, such that they have difficulty with orthostatic hypotension whenever they sit up or whenever they stand up. So you may have recommendations to place TED hose or abdominal binders on spinal cord injured patients to provide them with blood pressure support when they are standing. One very confusing issue that we deal with on the rehab unit, on the acute unit, and it is likely to be an issue on an inpatient psychiatric unit is the presence of a neurogenic bladder. And it's not only hard for the patient to understand how to manage this, it's also hard for staff to understand the rationale behind it, because it's really confused. It's basically really confusing, but it's really important to address because incontinence that's basically unanticipated, where a patient either has a diaper on or doesn't have a diaper on and is incontinent in bed or in their wheelchair or while they're walking on the unit, can be distressful for the patient. Just a little bit about history about neurogenic bladder and spinal cord injury. Before we figured out how to manage bladder function, the renal mortality in the early 1900s was as high as 95%. When we figured it out, renal mortality really went down to less than 3%. So it's really important for us to continue addressing bladder issues, whether they're in the community, whether they're in the hospital with us. And there are there's a lot of different bladder types, but there are two main types. The most common that we probably see is an upper motor neuron bladder. So somebody who has a lesion probably above L2-ish. And these bladders tend to be spastic bladders. They want to spasm. If things are not right, the spasmed bladder may actually send urine up in the wrong direction and put the patient at risk for hydronephrosis. There's also evidence of urinary retention where the patient is not able to void. And certainly a lot of these patients can't tell that their bladders are full or they need to void, and they can't initiate a void on their own. The second type of bladder is one that we see in patients who have cauda equina injury, so injuries much lower at the rootlets of the spinal cord. And that's a flaccid bladder, basically a bladder that blows up like a big balloon, and you have a risk of the urine overflowing. What we want to try to avoid in these patients is infection, the risk of hydronephrosis, that's urine heading up in the wrong direction, up towards the kidney, and ultimately kidney damage. The way we manage that is actually with catheters. And interestingly, catheters have been around since the Greek era. Who knew? Apparently they've excavated sites, and they determined that something that looked like this was a catheter. Why I wouldn't think that was like an instrument or a pipe or something like that, I'm not sure. But they apparently identified this as a catheter, which was probably used for something like BPH back in the day. And it was made of metals like gold or silver, which is kind of cringy when you think about it, but times have changed, and bladder and catheters have evolved over time. Here's a rendering from way back in the day. I wish I could give you what year that was developed. But actually with the advent of, I think it was the Firestone Rubber Company, like as in tires, that's what they started to develop rubber catheters. We all know about Foley catheters. We're going to talk about this type of catheter, which is a catheter that's not left in and is used for intermittent catheterization. And now they have super compact catheters, which are about the size of a lipstick container that patients can be using. So in terms of management of a bladder, it's important to achieve continence. And I put this in quotes because it's not continence the way that we think about it, like we know when we need to go, we initiate a void, and we're able to pee on our own. But we want to be able to have the patient store urine in a low pressure bladder, not going in the wrong direction. We want to provide them with a means to empty out their urine, and we want to avoid interval leakage or incontinence so that they don't have to wear a diaper. Here's let's see. In the short term, we can manage bladders with the use of a Foley catheter. However, this is not optimal in terms of the long-term management of bladders due to the risk of infection. So for long-term management, we look to what's called an intermittent catheterization program. Basically, that consists of in and out catheterization every 4 hours to ensure bladder emptying, which is something that is probably not very familiar with staff that is not used to treating spinal cord injured patient. The goal is to cath every 4 or 6 hours, almost like you're going to the bathroom on your own. We'd like the volumes to be less than about half a liter to prevent overflowing of the bladder. And our goal is to have the patient be dry in between the catheterization so they don't have to wear incontinence pads. So on the unit, staff have to have some familiarity with bladder management so that they can assist the patient in being regular with performing catheterization. We have to avoid chronic Foley use to prevent the risk of infection, and know that just diaper use may not be enough, especially if the patient has problems with urinary retention. So here's the question then after that section. Foley catheters are the device of choice when managing neurogenic bladder in spinal cord injured patients, true or false? So it is correct that we try to avoid Foley catheters whenever possible because it leads to risk of infection. And also from a psychological standpoint, it'd be better to not have an appliance attached to the patient if at all possible. So to manage with an intermittent catheterization program, that would be much more on par with community practice. Okay, same goes for the management of bowel. So here's a question. The ability to manage bowel movements is lost after a spinal cord injury. It's a trick question. Sorry for the trick question. It is kind of a trick question because the key here is manage, the ability to manage bowel movements. Certainly if they have a significant spinal cord injury where they can't feel that they're full, where they're not able to initiate a void or to stop a void, start or stop a void of their bowels, then it's difficult, but we do try to manage their bowel function because again, from an ability for self-image to be able to be in control of their bodily functions, it's important to get them on a bowel regimen. So it is possible for them to manage when they're going to have a bowel movement. Okay, for URI, here's how it goes. Usually we eat, it extends our stomach. That extension of our stomach initiates a gastrocolic reflex, which propels stool down our intestines and into our colon, and ultimately it's stored in the rectal area. When we need to void, we experience some relaxation of that internal sphincter, and that's usually the clue, like, let's get to the bathroom really fast. And then we voluntarily relax our external sphincter, which then results in a bowel movement. Of course, in a spinal cord injured patient, they may or may not be able to feel that their rectum is full. They may not feel this relaxation of their sphincter, and they may not be able to voluntarily relax their external sphincter. So how do we manage that? The reflexes for many of these patients is still intact, but we're going to be using that reflex to try to control when they have a bowel movement. Because ideally, when people have a spinal cord injury, we would much prefer that they not have their bowel movement incontinent in bed where it's a whole production and trying to clean up a bowel movement that's occurred in bed. We'd also not like to have them have a bowel movement when they're mobilizing within the community and in their wheelchair. So our goal is to establish a program that allows a patient to initiate a bowel movement when they're ready for it. And how do we do that when they really can't perceive that they need to go and can't start and stop their own bowel movement? If they have an upper motor neuron bowel, so a lesion above approximately L2-ish, then they can potentially void by a reflex void. And basically they take advantage of all of those reflexes, which I mentioned earlier, where the stool is reflexively moving through the bowel and down to the rectum. And then they do what's called digital stimulation, which is depicted here, stimulates the reflex to actually void. And with the use of stool softeners and either a suppository, which provides additional stimulation, we hope to have the patient reflexively void. And the only way that's going to work is to have the patient train their bowels to do it, which means we should schedule bowel movements to occur at the time of a meal. So either breakfast or dinner, and to just stick with those meals, and then to do the bowel care around those times. And that sounds pretty easy, but in a hospital, it's pretty problematic when people are not necessarily understanding the whole concept of bowel care. So even though somebody may have been incontinent of bowel at 5 in the morning, if their bowel care is supposed to happen at breakfast at 9 o'clock, they still should go through the motions of digital stimulation and suppository, because you're trying to train their bowel to evacuate when they're ready for it, as opposed to when they're out and about in their wheelchair or out and about in the community in a shopping or in a restaurant. So whatever we can do to help maintain a regular program of bowel care the same time every day that helps to train the bowel to go will allow the patient to gain some control over their bowel function, which of course would be beneficial for them, especially if they are somebody who mobilize often into the community. For a lower motor neuron bowel, those are flaccid type of bowels. Those are sort of from cauda equina injuries. They don't have this whole reflex activity. And unfortunately, the only predictable way for them to empty their bowel is via digital disimpaction. Now, their tone is decreased in their rectal area. So inserting their finger or fingers into their rectum to digitally disimpact is a little bit easier because they don't have a lot of tone down there. But really, sometimes that's the only reliable way for them to achieve this. So in summary of the bowel care, instead of having unexpected episodes of incontinence, the goal really is to train the bowels to empty when the patient is ready, as they were doing prior to their spinal cord injury. Other things that are potentially distressing to patients related to spinal cord injury is spasticity. This also occurs, and we'll talk about this briefly when we talk about traumatic brain injury and stroke. So in upper motor neuron injuries, there's an injury, you have excess fiber sprouting, excess reflex responses, and you have muscle overactivity, which results in something that can look like this. So some of you have seen patients who have had strokes, head injuries, or spasticity where their arms are either involuntary flexing, their hands may be gripped, their legs may shoot out because of spasticity, or actually flex up towards their body involuntarily. It's problematic because it could be painful, it can impact functional use of their extremity. It might limit their ability to transfer because their spasticity is so bad that they can't transfer safely. And it can potentially result in disfigurement or loss of range of motion, such that we may be getting here, where now this patient is moving towards having an elbow flexion contracture. So we treat spasticity with splints. So patient might come to your unit with splint use. It's important to have the splints intact and also to check their skin to make sure they're not having issues. And they also may have lower extremity splints, which may be needed for proper positioning and skin management. To break up some of the spasticity that might be present, it's important to have them seated well in their wheelchair in what we call neutral positioning. So basically flexed at the hip, flexed at the knees, and knees planted in a 90-degree angle. That helps to break up any flexor tone or extensor tone that might be occurring with the patient. You may see on their med list some medications such as baclofen is the most common one you'll see, or tizanidine. We do try to avoid diazepam for obvious reasons, and sometimes we have to resort to dantrolene as well, which is less common, but sometimes we have to use that as well, in which case they would need to have their LFTs followed closely. On occasion, you may see me on the unit as well performing Botox injections to spastic muscles. What that basically does is weaken muscles that are problematic in terms of contraction. You could kind of see what's going on over here where he's got a clenched fist. So we're injecting forearm flexors, which actually affect grip in the hand. So here, before I move, I mean, there's so many different things we could talk about with spinal cord injury, but there is one more thing that I'd like to talk about medically before I move on to a couple of psychosocial issues with respect to spinal cord injury. And that is this. Here we have a 35-year-old male with central cord syndrome. So you know it's something in his cervical spine. He complains of a severe throbbing headache, flushing, nasal stuffiness, and he states that something terrible is about to happen to him, that was going to happen to him. The first thing you should do is review his meds, check his blood pressure, obtain a tox screen. Great, some of you are steps ahead. It is true that we want to check his blood pressure. So what we are probably seeing is the manifestation of autonomic dysreflexia. It is the one rehabilitation emergency that we do have. It affects patients who are the levels T6 and above. As I mentioned just briefly a minute ago, people who have spinal cord injuries may be at risk for autonomic dysfunction. And so what's happening here is that if you or I have some sort of noxious stimuli applied to us or happen to us, what may happen is our blood pressure may go up and we may become tachycardic. The way our body sort of auto-regulates is that to mitigate that increase in blood pressure, we usually have potentially splanchnic dilatation of our blood vessels to have our blood pressure go down. And our vagus nerve, which is not related to our spinal cord, kicks in and slows our heart rate. So what will happen is we'll vasodilate, lower our blood pressure, slow our heart rate to help lower our blood pressure, and that's how we would potentially deal with it without even thinking about it. In a spinal cord injured patient, their spinal reflexes to vasodilate are disrupted because of the spinal cord injury right here. So they get some sort of noxious stimuli, and in a spinal cord injured patient, it's usually most commonly a full bladder. Either Foley's kinked or they need to be cathed. They get the noxious stimuli, the blood pressure goes up. Because they can't vasodilate, their blood pressure keeps on going up and up and up, and really to stroke levels like 220 systolic plus, but what is intact is their vagus nerve because it's not related to their spinal cord. So you see a paradoxical bradycardia. So you'll see an elevation in their blood pressure that just basically soars to a paradoxical relative bradycardia. And that's classic for autonomic dysreflexia. On top of that, this is the strangest thing, where above the level of their injury, because they're able to vasodilate, they're all sweaty and flushed, and their nose gets stuffy. But if you touch below their spinal cord injury, the level of their spinal cord injury, they're actually dry and kind of cold. So that's sort of classic. The other thing that apparently classic is this sense of impending doom, like something bad's going to happen. So that's another classic thing that we see. So what do we do for this? Basically, we have to get control of the blood pressure. So what you can do is to make sure your staff knows that if somebody is complaining of a headache who happens to be spinal cord injured, make sure you check their blood pressure if they're complaining of a headache. If their blood pressure is elevated, slap on some nitropast or something that will affect their blood pressure, and go searching for whatever the etiology of their noxious stimuli might be. Might be cath, maybe a bowel impaction, again, a full bladder, something poking into them that they, in their bed, it's not really quite clear, but basically to go searching for what that noxious stimuli is and go ahead and remove it. Let's see. Okay, wanted to touch really briefly too on some of the psychosocial sequelae regarding spinal cord injury, and that depression rates are higher in our spinal cord injured patients. They also have a higher risk of anxiety. Risk factors include males, low income, and more severe. ISS refers to their injury severity score. So those who are more severely injured. We find that suicide attempts accounted in this particular study. There were 2 reviews done in the UK, and they found that suicide attempts accounted for 6.8% of spinal cord injury, usually due to jumping or falling injuries, and that those patients who had a spinal cord injury due to a suicide attempt, death by suicide was higher in that patient population. the patients at most risk were those within the first 2 years after an injury, and the major risk factor tended to be those who had a pre-morbid psychiatric diagnosis. So risk assessment and psychological intervention is crucial. At Laguna, we're really fortunate because we do have psychiatrists and neuropsychologists on staff who help to assist us with the management and screening of patients who have the potential for depression and can help us with medication management. Quickly moving, we're going to switch gears really quickly to traumatic brain injury, which also can be correlated with stroke. Incontinence, bowel bladder issues are also common with this patient population. We don't really manage them with catheterization, but we do tend to try to manage them with a timed voiding program, which is basically saying we're going to toilet you every 3 hours or every 4 hours to try to maintain continence. We found that incontinence is strongly correlated with poor discharge functional status, longer lengths of stay, and poor return to work. So that really may be a reflection of how severe their injuries are, but we do whatever we can to try to gain some control over their bowel and bladder function. They also have difficulty with spasticity, as do our spinal cord injured patients. The interventions are the same: splinting and Botox and positioning. This is something that unfortunately we see quite a bit of, even on our own unit at times, is where we have the patient poorly positioned in a wheelchair with their hemi arm dangling down from, at their side, with them slouching in their wheelchair. It's important to get them in a proper position, not only for their safety, but also for their comfort. So you may see, especially here, when you have somebody who's hemiparetic, they often have shoulder pain. So to have their arm dangling like this actually puts them at increased risk for shoulder pain. So it's important to put their arm in something like an arm trough to provide them with support. The other thing that's also occurring as well is we want to make sure that their strong side, their non-hemi side, is in contact here with the floor so that they can use their leg to self-propel in conjunction with their strong arm. You may see such devices as the arm trough, which I mentioned, or a lap table, which would be important. So don't let your patient's arm dangle into their lap, because it puts them at risk for shoulder pain. Other devices include built-up plates so that they can use one hand and they don't have to use their other hand to steady their plate, and they just can pull the food up in this kind of manner. And one of the most common causes of falls that we see is falls out of wheelchairs as patients try to reach for objects on the floor or in their drawers. Not realizing that their hemi side's not going to save them, that they start to fall. So reachers are also important to use. We also use orthotics, as we do with our spinal cord injured patients. The walking devices are a little bit different. This is a hemi cane. Since they're hemiparetic, you don't really have two hands to hold onto a device. So this is a one-handed hemi cane device, which provides a wider base of support than the quad cane or a cane. This might be one of my last questions. Most common cause of TBI, we'll go through that really quickly. Great, you guys are right on track in terms of common causes. It is falls, which is the leading cause of traumatic brain injury, followed by motor vehicle accidents. And there's a lot of falls in the elderly population, which we're seeing obviously more and more, not only resulting in traumatic brain injury, but also resulting in spinal cord injury. Something I need to just touch on fairly quickly here is the Rancho Los Amigos scale of cognitive functioning, which you may be familiar with. It's how we look at cognitive functioning in traumatic brain injured patients. Level 1 is somebody who is very impaired, who basically has no response to stimuli. This is somebody that generally you might see in an ICU setting. And as they start to awaken, so to speak, they may go through these different levels of recovery. Some patients get stuck in one of these levels. Some people stay in one level longer than others. But generally what happens is they start to respond. When they start to respond more, they become more agitated. And then after their phase of agitation, they become much more sort of automatic in their functioning. And then they become more purposeful. The reason I put this here is because if you are doing inpatient consultations, you'll probably get consulted when the patient is level 4 or through level 8. That's when they're really confused and agitated, when they may be causing issues on the unit in terms of behavior, aggression, wandering, desiring to leave. This is when we often have people either receiving a psychiatric consultation for assistance, or sometimes we get called as well. In the outpatient setting, or even in the inpatient setting, as people become more and more functional over time, you may see patients who are more level 8 and 10. They're living in the community, but they're having difficulty with depression. They're having difficulty with memory, frustration, anxiety. So these different levels of Rancho in the Rancho Los Amigos scales, you'll probably be seeing either on the inpatient unit, on the acute units on the wards, or even as outpatients. Agitation is a problem that we see a lot of in traumatic brain injury. It's probably higher in incidence than 37%. In the back in the day, they used to use Haldol quite a bit. We don't use that as much. And certainly we also try to avoid the use of benzodiazepines. Here are some medications that we commonly use for agitation and aggression: propranolol, valproate, carbamazepine, amantadine, which is used often early, sort of in the intensive care unit stage. And for really severe recalcitrant agitation, it's not uncommon to be using quetiapine. The challenge, though, is that we're really not clear on how these medications might impact neurorecovery. And so there's a lot of study into that as well. Depression, like in spinal cord injury, is a very common sequela from after a head injury. Factors associated with depression include low economic status, less education, lack of close personal relationships. And in line with depression, in terms of intentional self-harm, it's the first leading cause of TBI-related deaths in 2014. I wasn't able to find something more recent than this, but it's significant concern. The potential predictors are a history of prior suicide attempt, a history of bipolar disorder, and having less than a high school education. Unfortunately, there's limited evidence for the optimal treatment of depression and TBI. Again, it's not clear how these medications may impact neurorecovery. More commonly used are SSRIs, which appear to be perhaps better tolerated than TCAs. But if left untreated, we find that patients have demonstrated poor psychosocial functioning, cognition, and community integration. So that was sort of a whirlwind of TBI, spinal cord injury, and stroke. I'm hoping that some of the learning objectives were met. You were able to find a little bit about the statistics with respect to spinal cord injury and TBI. We talked about classifications, the Asia classification in spinal cord injury, and the Rancho Los Amigos scale in TBI. We talked a lot about medical management and sequelae, primarily about bowel and bladder, very important issues for our patients, as well as spasticity as it relates to pain and skeletal deformity. We touched on some commonly used devices and just briefly touched on the psychosocial implications, which we often turn to you as our colleagues to help us with this as we manage these patients on both our unit and also as outpatients. Thanks very much.
Thank you so much, Lisa. We have about 1 minute left. If anyone has any questions, you can either just come off mute or put it in your chat.
That was kind of a lot.
Well, I had one real quick question just about sexual functioning, sexual performance, and how that kind of gets integrated into the early recovery.
That's a really good question. There are, for spinal cord injury, when patients express that they have either a desire to try or they have questions about it or things like that, there are devices that could potentially be used to facilitate sexual functioning or penetration if there's an issue with respect to that we do discuss with patients. At Laguna, there had been the opportunity also to kind of try it out as well. We try to give people the opportunity to do that as well because it is super important, but we try to provide them with the education regarding that. And we also turn to our urology colleagues for any devices or surgical interventions that might be necessary depending on what their spinal cord injury is like.
Okay, well, thank you. Well, we're at the hour, 2 o'clock. And once again, thank you so much, Lisa. And we'll go ahead and sign off and thank you, everybody.